Yeah.
And if I go to this individual systematic review, I think not all listeners of the podcast are familiar with. So basically, you ask from other researchers to get actually the raw data or the variables, and then you pull together different studies. So could you explain a little bit
Yeah.
more how you do
Yeah.
it?
Yeah, so like I said, in a conventional systematic review, you review the literature, and you rely on what is published in the literature to do your meta-analysis. So you take effect estimates from the literature published in the literature, and you pull them all together statistically pull them all together in a meta-analysis. What we did here is asking the really individual data and of all the cohorts, and then combining the individual data, and that has the advantage that you can do analyses that weren't done by the original authors. So, for example, male female stratification. That's something that we don't see always in the literature, and having the individual data, you're able to actually do that. You can also look at, for example, interaction effects, or you can adjust for certain confounders, or even do mediation analyses beyond what was done by the original researchers. So that's a big advantage, I think. Also, you can harmonize analysis methods. So, for example, in how physical activity is defined, we in our analyses use 4 categories of physical activity: sedentary, low, moderate, and high. And having the original data really helped us to harmonize that definition, and to use that definition across all the cohorts and all the data that we had. So there's a lot of advantages, but there's also disadvantages, because when you do a harmonization, you sort of rely on the weakest link, I always say. So on the lowest level of detail. So, for example, if you're harmonizing a variable BMI, of course, it would be very if you harmonize BMI across a lot of different studies, it would be very good if you would be able to use BMI as a continuous variable and then harmonize it. But what we noticed when we did our harmonization is that when doing that, there's a couple of studies who haven't used the continuous variable, but have categorized the variable in different categories, and then the authors have already reduced that level of detail, and then we as researchers who do the meta-analysis rely on that level of detail, so the harmonization procedure leads to losing detail, and that's I think a bit downside of the individual participant meta-analysis.
And I guess it's quite a bit of work to start going through different studies data again.
Yeah, you can say that. Yeah, it's a lot of work, and in this particular case, we really underestimated the amount of work it took. I think we started the project in 2018 as a 1-year project. We got funding from our Dutch Healthcare Council to do the project in 1 year. And really, well, getting the data from the different cohorts, that already took us about 1 year. So going through the motions of making agreements with people, sometimes having application procedures to get the data. That already took 1 year. And then we had to start the harmonization. Then we had to do the analysis. And we're now like 4 years down the track, or 3. And we're now close to submitting our first paper. So it really took a long time. I think it's really fun to collaborate with so many people and do the job. And like I said, it has a lot of advantages to do an analysis like that. You can really do new novel things that haven't been done in the literature so far. But it's a lot of work, and there's some downsides as well.
No, that's I think important point for our listeners, that if you're going for individual systematic review, it will be probably more work than you imagine, and for you it has been like 4 times, has taken 4 times more than what you thought. Am I right?
Well, I don't not as much actual work time, so to say. So in the beginning, like I said, it took us 1 year to go through the motions of applying for the data and making agreements and then getting the data. But there's a lot of waiting time involved in that. So I think in full time work it may not even be too bad, but there's a lot of back and forth through with all the partners involved, and that in particular takes a lot of time. Not so much work time, but more, but also waiting time and waiting for people to get back to you. We have now 22 data from 22 studies that we harmonized, you can imagine that's going back and forth with 22 different partners, and more than one person typically per cohort. So it's a lot of people management involved as well. But I'm happy that we have now a PhD student on board who's helping me with the hard work, because when I started the project I was still a postdoc, and I had quite some time on my hands to do all the things myself. But I grew a bit over the year. I'm now assistant professor, having PhD students of my own to supervise, and having all sorts of other tasks as well. So difficult for me to do it all, and I'm happy that we have a PhD student now who's helping me out. And
And what would be your advice for people doing individual studies, that in later it would be easier to do this kind of individual systematic reviews? You said that if they kind of reduce the data already, that decreases the quality of this kind of review. What would be the other points that you would like to say?
So indeed, that's I think the most important point. Reducing the amount of reducing your level of detail in the data is actually never a good idea, because it's for example, the BMI example. If you use the continuous variable that has a lot more detail, and narrowing that level of detail down to categories, or even dichotomizing it, really has statistical implications as well, because it reduces your statistical power, but it also has makes it more difficult for people who do an individual participant meta-analysis to because they then rely on that level of detail. But people have reasons for doing that, of course. So we noticed, for example, one study, they had issues with sending individual participant data abroad, and they only could send data abroad once they were not identifiable. And in order to make data non-identifiable, they had to categorize it. So sometimes it's not that people really want to do this, but yeah, of course they have good reasons to do so. Sometimes because of the legislation in place. And I think another thing in general is that we should maybe think of ways in which we can come up with more harmonized ways to already collect data. If we, yeah, I think physical activity is the most prominent variable where we saw a lot of heterogeneity, a lot of different ways in which, in particular, occupational physical activity was measured, defined, categorized, you name it, and yeah, of course, it's yeah, we can. We as systematic or as meta-analysis researchers can try to harmonize that data and can try to come up with common ground and common ways to to harmonize the data. But it would of course be much better if at the very start of a project already people start collecting data in a way that it can be harmonized in a later stage. So I think having good definitions for how we should capture variables, and I think mainly occupational physical activity is very important to capture that in a good way, because we see that we have a lot of different definitions there. I think that's the most important thing.
And usually when we talk about assessing physical activity device-based, it's usually either thigh-worn or wrist-worn accelerometer that we get kind of estimate of leg movement. But in occupational work, occupational physical activity, it's quite a bit also about upper body movement. So do you have any good simple ways to measure upper body work?
No simple way, I'm afraid. I think the device-based measurements. So typically the use of accelerometry. I think public health researchers, physical activity researchers are used to wear the devices, to have the participants wear the devices on their belt, on their hip, or maybe on the thigh, or maybe on the wrist, and then using the data to come up with physical activity defined in sedentary, light, moderate, high intensity, but the accelerometers actually have a lot more different ways that they can be applied. In the beginning of in the start of our conversation, we already talked about how I used biomechanical principles and how I built up models of the human body with different types of data. Also, data from accelerometers can be input in these kind of models. So if you put an accelerometer on your trunk or on your upper arm, or well, actually everywhere you like, on every body part that you like, you can use that input from those accelerometers in a biomechanical model, and once you have that model, you can basically calculate loads in every part of the body.
And of course, when we are collecting data in the field and long durations and have a lot of participants, we cannot collect everything. But if, for example, we could have 3 accelerometers on one person, what would be the best locations that you think would biomechanically and also from the kind of loading point of view, we know that, for example, low back pain is common and shoulder problems are common. So what would be the best placements in
Yeah.
your opinion?
Yeah. So I suppose it depends a bit on what you're interested in. Earlier on, you gave the suggestion for low back load to place a motion capturing device, can be an accelerometer
Mm,
on the trunk to measure the inclination of the trunk or the upper body.
mm,
I think that's a very good idea if you're interested in low back load. But if you're interested in shoulder load, then it may, of course, makes more sense to place it on the upper arm. Or if you're interested in elbow load, it makes more sense to maybe place it on the forearm. So I suppose it depends a lot on what you're interested in, and
mm,
whether you're interested in the load on a certain joint, or whether you're interested in postures, or whether you're interested in intensities. And I think this really sums up the complexity of the field of occupational physical activity. I think, leisure time physical activity in public health is like I said before, is typically assessed by assessing level of intensity of physical activity. So sedentary, light, moderate, and high. But for occupational physical activity, we have so many different modalities. So we have the loads on the joint, we have the intensity, we have the postures, we have frequency, duration, and yeah, I don't think we as researchers have been able to come up with a really good definition to capture that, and that's actually something I would like to do in the future. Like to be part of, at least, like coming up with a really good definition for how we should capture occupational physical activity.
mm.
Because I don't think we have that yet. Good definitions to measure it, but also to define it, so to say.
Mm, mm. And if I have understood right, the occupational physical activity, it's easy to understand it's related to musculoskeletal problems, but it's
Yeah,
also related to metabolic health problems like
yeah.
cardiovascular disease. And I think one of the reasons is probably like if you do overhead work, your blood pressure stays high during the day. Have you looked any of these kind of upper body work and in relation to cardiovascular disease in your reviews?
Well, not so much in my reviews, but when looking at the literature, I think what we see is that a lot of the tasks that we consider physically demanding at work, so lifting, uh, postures for prolonged period of time, and also working overhead. I think these are things that we see in the literature to be associated with increased heart rate, sorry, increased blood pressure, and yeah, we started with my story about cumulative loads. Once
Mm,
those things, heart rate and blood pressure, accumulated over the day, uh, stay relatively high, then that can become a risk factor for cardiovascular health, indeed.
mm. Yeah, yeah. I think this is really interesting. I I have a bullet points of our discussion, and we are in the first one. First one now. It's been really interesting. So you have also worked on the active worker consortium. Could you tell more about that?
Well, that's actually the individual participant data meta-analysis I was talking about.
Okay,
That's
okay.
that's how we called it,
Yeah,
the
yeah.
fancy name. Yeah.
Yeah, and how are your future plans on studies? What kind of things you are planning by yourself and
Yeah.
with your PhD students?
In this domain, you mean, so
Yeah,
in the
yeah,
field of occupational physical activity?
yeah.
Yeah, I think we see uh, uh, quite some issues in with the literature as it is right now. And once I did my first systematic review, once we published the first systematic review in 2018, there was a nice editorial by Roy Shepard, um, who actually identified a number of issues of around our review, but also around the occupational physical activity literature in general. And I think addressing those issues, those limitations, that would be really important to really progress the field. Uh, I think one very important one, or maybe the most important one, is confounding. That's sort of criticism that we always get when publishing research in this field, that the effects of occupational physical activity on health are confounded by a range of different variables, most prominently probably the socioeconomic
Mm,
variables like income and education. I think a lot of studies in the literature try to address that by trying to adjust for it. But yeah, of course, the question always is, have they done a good enough job doing so? And I think that discussion will keep on having once we keep on using observational data to only look at this topic. So observational data, in my opinion, will always have the issue that we aren't sure whether confounding residual confounding is sufficiently addressed. So I
mm,
think in order to move forward, we really need to come up with better analysis techniques to address this. We can, for example, think of mediation analysis to do that. But even better, I think, would be to come up with new study designs. We hardly see any experimental study designs in the occupational physical activity field, and I think having those kind of study designs would really help us to progress the field. That's the most important thing. I would probably like to work on in the future. And then the other thing, I already mentioned it, is finding good ways to measure and also define occupational physical activity, and being able to get people on the same page on how they should do that, and
mm,
actually having people really applying those kind of assessment methods and definition methods. I think that's also a very important point for the literature to progress.
mm.
And there's
And
more smaller bits.
yeah, and you mentioned experimental studies and basically probably measuring like acute variables. You come from the biomechanist side. Do you think it would be biomechanics, or would you look some biomarkers in the blood, or how would you do the experimental ones?
Yeah. Well, that depends again on what you're interested in. If you're coming from a musculoskeletal health point of view, then it would make sense to look at the biomechanical loads on the body, and look at musculoskeletal discomfort or musculoskeletal pain. Musculoskeletal discomfort is like a precursor of musculoskeletal pain. So
Mm,
that's often used in in laboratory studies. But if you're interested in mechanisms for cardiovascular health, it would make sense to look at more cardiometabolic outcomes, heart rate, blood pressure, these kinds of things. So yeah, it really depends on what you're interested in, I suppose.
And final question in this, you said about metabolic health effects and musculoskeletal. Which one do you see in general as a bigger problem? Is it the musculoskeletal bigger problem in occupational physical activity?
Uh, oof, that's well. I think what a lot of people don't realize is that musculoskeletal health is a big issue in our society. Uh, there's the global burden of disease studies that assess for each disease that we have what the global burden is, and musculoskeletal health typically scores really high on those lists. So low back pain, neck pain, shoulder pain, lower extremity pain are all very high in that list, probably in the top 10. So I think musculoskeletal health is a very important topic to study. But I think we already have quite a lot of literature on musculoskeletal health, because that's typically the field where occupational health researchers have done a lot of research in. So yeah, cardiovascular health, on the other hand, is an outcome that hasn't been studied much in occupational health. So yeah, I think to answer your question, I think musculoskeletal health is very important. It's a big issue for our society, and for that reason, it's important to study. But cardiometabolic health is a bit understudied yet in the occupational health field. So also very important. Yeah, and of course also a big problem in our society.
This was really interesting. So thanks, Peter, for taking time for this recording.
No problem.